I just wanted to sort of lay land on what I hope to go through today. Please feel free at any time. When I'm really excited about something, which happens to be the case with LGBTQ health, I talk really fast. So I'll try and slow it down a bit, but also raise your hand, ask questions. I'd love for this to be more interactive. So essentially, I want this as an opportunity for you to get to know a bit more about me, not just personally, but also professionally. I'll start by defining some key concepts, then talk about the growing size of LGBTQ communities, and then dive in and specifically describe some health inequities, and then end with talking about some ongoing research and practice. Also throughout, as I talk about these things, I'm going to pepper in some of the current research that I have going on. I'm really excited that a lot of my collaborators are here in the room today, so be ready for me to point and call on you. So let's go ahead and get started. All right, so you heard about my professional background, or excuse me, educational background. I started off at UNC Chapel Hill, and then I went on and did my master's and doctorate at Harvard, and then from there, my postdoc at Brown. I do think it's really important to say the way in which I come to this work. So I come to it as an ally, right? It's very different to study, to work, and do something when it's your own personal lived experience. And I think understanding that difference is part of what helps me do my job well. In that, I know where my limitation ends. It's one thing to read, to connect, to have family, friends explain to me their experience. It's very different in your own physical body to be walking down the street and to have that sense of fear when you're questioning your safety, when you're questioning what it is to engage and disclose those relationships with family, friends, in the professional space. And so I do think it's really important for me to say that the way in which I come to this work, is as an ally. It's also a great opportunity to show a really cute picture of my son in fairy wings. So, okay, why do I do this work? Great question, if I may say so myself. You know, I grew up overseas. My dad was in the Foreign Service, my mom an elementary school teacher. And so I lived in Swaziland, now called Eswatini, and then Egypt. And I think in all of these experiences, I became much more comfortable with what it is to be the other, the outsider. I've used a few of those experiences moving from California to Alabama. And that was really what led me to study public health. And so I was really interested in global public health and started doing HIV research in Brazil. And it was when I was living in Brazil, ironically in a convent, but that's for another story. And then I was sitting in HIV clinics day in and day out, and I saw the people coming through the door, right? And it was just very clear. There's the statistic of the way in which HIV disproportionately affects LGBTQ individuals. It's one thing to read the statistics, it's another thing to actually sit there and see who's walking through the door. Also in Brazil, I would say they're way ahead of where the US is in a couple of things, but they actually don't call it, there's not a direct translation. It's not public health, it's called collective health. So the research team that I was a part of was largely made up of LGBTQ individuals. And so every day we'd have our work, our research, and then we'd go and have maybe a few drinks after the fact. And really there started the seed of what became one of the first LGBTQ clinics in the northeast of Brazil. And it was through that work, the friendships, the collaborations, et cetera, that I saw that HIV, while hugely disproportionate in terms of its impact on LGBT communities, can't be what we lead with constantly, right? To constantly talk about risk and HIV and condom use and fill in the blank, people are going to stop listening. And instead placing HIV in the larger context of health, right? Primary care, dental, vision, and then placing health in the larger context of education, housing, and all of the other things that we often are thinking about as even primary to our health. I think it was through that work that then I said, okay, you know, I really do want to focus in LGBTQ health, and I've got to consistently and constantly think of ways to make this one piece of the larger picture that I'm trying to address. So living in sunny California, and it was during the pandemic. I actually lived right outside of LA in this area called Topanga Canyon. And I saw the job description for this. And I was like, wow, okay, I've never seen a position like this in my entire life of doing LGBTQ research. Importantly, LGBTQ was in the title, right? Which is very different than endowed professorships that are named after someone who's had a colorful past, right? And so it's not only that LGBTQ was in the title, but it's also that it's in the deep South, and you'd expect something like this out of San Francisco, Los Angeles, New York, etc. And then not only in the deep South, but at a public institution. And so I know that academics in particular love to talk about titles, right? And I'm often insistent on saying the whole entitled title that I have, because it's a massive statement in terms of UAB, where they stand, and I think what they're hoping to do. And I think often I started to hear this as I considered the move from California, and I'm already tired of it living in Alabama all of 1 year, this constant othering of Alabama, right? And this constant placement of Alabama as 49th, 49th, 50th, etc. I think this position is an example of what it can mean to be quote unquote at the bottom of the list, that it gives an opportunity for innovation and doing things completely differently than is done anywhere else in the country. And I have to say, since moving here, in terms of my friendships, my collaborations, and I hope as you see the types of things that we already have up and running is really an illustration of all the work that's been happening here. And my position is not to start it. A lot has been happening here. It's really how can I collectively bring people together, raise the visibility, and then further grow it. All right, so first I'm going to start with key concepts, right? And on one hand, like this is super basic. And on the other hand, it's surprisingly complicated. So let me dive in a little bit. And again, raise hands, ask questions. But hopefully as I start to get into this, you'll better see why I think it's important for me, at least, to clarify how I come to these terms and concepts. Because I think especially when we say something like sex, gender, sexual orientation, gender identity, we can all think that we're speaking the same language, and often then in practice, how we operationalize this. And as we think forward to what are the programs and policies, the definitions that we bring to the table are very different. So the definitions that I'm using today came out of the most recent NIH report, where they did this very big panel that only had one person from the South involved. Just, as a note, we're working on it. And in many ways set the new standard for what the question should be in health surveys going forward. So first, definition of sex: a multi-dimensional construct based on a different anatomical and physiological traits. So the dimensions, sex traits include external genitalia, gonads, chromosomes, hormones, and secondary sex traits. So I'll be very honest and transparent, right? I am quote unquote an expert of LGBTQ health. I am working on an LGBTQ health class that I'll start teaching in January. I hope you'll take it. I'm working with an undergrad to help build out, I have the peer-reviewed articles, but the media, right? Because I think it's really important that we look at this not just in peer-reviewed articles, but then also in terms of like what this looks like in practice, movies, TV shows, etc. And so we sat down on day one and we're talking through some of the basics. And I said, well, gender is socially constructed and sex is based on biology. And she's like, no, it's not. I was like, yes, it is. And what happened in this back and forth was this discussion and really deconstruction of the idea of sex, right? That often we say it's sex assigned at birth, right? That baby is born, that there's a quick review of genitalia, and based on that, the sex is then assigned as male or female. In some cases, maybe intersex, but very rarely, right? At the same time, almost every medical text, when we talk about sex, is based on these multiple dimensions of what makes sex. And really at birth, only one of these is like quickly defined. So that's based on a social ascribing of something. And often it isn't until someone later in life, either there's a medical complication or trying to go through reproduction or some part of it that there's then further inputs to define ways in which that there may be not so much clarity about these categories. So that's why I bring up even these basic terms and concepts, that in terms of sex being biological and gender being socially constructed, it's really complicated when you start to peel away the layers. And again, even when I first heard the term of sex assigned at birth, I was like, it's a lot to say. But as I thought more about it, thanks to this 19-year-old undergrad, right, who is really getting me to question a lot of the things that I was trained in graduate school and I've been doing subsequently, was the idea that it's multidimensional. It truly is multidimensional. And then what are the implications as we go forward and we think about how does having all these dimensions impact health, programs, policies? All right, so in terms of different characteristics of sex, this is some of what I said originally, or what I just said, usually assigned as female or male, most often defined at birth. Sex traits are usually assumed to be unambiguous, but may not be the case. And then also that some of the sex traits can be changed or altered over time. So some of the categories include female sex assigned at birth, male sex assigned at birth, and then intersex individuals. So people whose sex traits do not all correspond with the single sex. All right, switching gears a little bit. So defining gender, a multidimensional construct that links gender identity, gender expression, and social and cultural expectations associated with sex traits. So there's these three different categories that often can mean different things. So gender identity is a core sense of how someone feels, okay? Gender expression is then the way in which you show that, right? So that's my heels, that's my nails, and all of these categories traditionally, right, are generally assigned to being female and male. Now, what we're seeing is the way in which more people are choosing to paint their nails or use a little cover up on their face, or I mean, you know, that these things are all starting to change, right? But it's recognizing that there's differences between how someone feels, how someone then expresses themselves, and then in terms of expectations, right? So those are the norms associated with being male, i.e. strong, aggressive, bold, female, polite, accommodating, nurturing, and then take all of that forward, right? In terms of the tracking that happens if you think about STEM versus social sciences, like we can go on and on about the ways in which these roles are created and then reinforced over and over and over again. So the key point here is just recognizing that gender identity, expression, expectations don't all correspond necessarily to the same gender. So some of the characteristics of gender, it's often conceptualized as binary, male, female. It's often used interchangeably with sex, though it's conceptually different. I mean, even some of my articles from probably even only 5 years ago would have said looking at gender differences, right? Rather than saying sex differences. I wish someone would have brought that up in the peer review process to say, hey, how about this, right? But I think it's also reflective of how quickly thinking in different fields are moving. It's often assumed to be determined based on sex assigned at birth, but may differ, and it can also change based on time and concept. So now talking about different gender identities. So there's transgender or trans. It's often a person whose current gender identity is different from the sex they're assigned at birth. So transgender man, that's thinking about, you know, where someone was assigned female sex at birth and they currently identify as man. Transgender woman, assigned male sex at birth and currently identifies as woman. If you're newer to this area, the key point is just pay attention to where they land and what they say, okay? Cisgender or cis is a person whose current gender identity corresponds to the sex they're assigned at birth. So I identify as cisgender. I was assigned female sex at birth. And currently, that is who I feel I am, how I present, etc. Non-binary. This is a category that is exploding, especially in younger individuals. So it's an umbrella term for gender identities that lie outside the gender binary. There's also terms such as gender queer, gender fluid. And the idea here is that rather than making a quote unquote transition, right, from one sex to the other, that it could be both. It could be somewhere in between. It could be just completely outside of that gender binary. So in terms of defining sexual orientation, so this is my new favorite word, multidimensional, right? Construct encompassing emotional, romantic, and sexual attraction, identity, and behavior. So I understand it can feel really nitty-gritty, right, on each of these to get into identity, attraction, behavior, and specifically as a public health person, these differences, I think, matter quite a bit, right? So in terms of the questions I'm asking someone, think about identity. So a person's core internal sense of their sexuality. So that was the similar definition as we're talking about gender identity, right? So that really gets into the core sense of who someone is. So if you're asking someone in a survey, you know, tell me your gender identity, right? That is tapping into who they believe they are. Attraction can be the capacity for sexual and or romantic feelings, but it may not be what they act on. Behavior is how a person interacts with other people sexually. So the classic public health example from this goes to HIV/AIDS, that initially CDC, other departments of public health, as they realized that there was a huge explosion in HIV cases, specifically among gay and bisexual men, And they went out and did a lot of messaging targeted at gay and bisexual men. And a lot of people weren't showing up. Why? Because a lot of people were either unwilling to identify as being gay or bisexual. There's also a lot of people who have sex with other men if they're a man, or women who have sex with other women, and simply don't identify with what it means to be gay or bisexual, because in many ways those terms associate with them entire cultures and communities. And there's a lot of people that say, that's just not part of my culture or community. And so for me, as a public health practitioner, I care, how do I say this given it's recorded? I care less, right, about, no, let me just flip it. What I care most about is the behavior that someone's actually doing to make sure that the programs and policies can meet those people where they're at and give them what they need, right? Now, whether or not that behavior, of course I care if that behavior is driven by internalized homophobia, transphobia, you know, a discriminatory legal and policy context, etc., right? But I think it's really important that we understand the differences between these things, how someone feels versus how they act, because the difference between those layers and levels and the way in which those layers and levels interact truly will inform how we can best serve that individual in figuring out what they need and how they need to be supported. Defining sexual orientation. So we have heterosexual or straight, lesbian, gay, bisexual. These are the categories that if you actually are asked the question, which let's be real, is very rare, okay, that you're most likely to see. Increasingly, as we talk about different terms being exploded, is pansexual. Pansexual, the best way I like to describe it is that you are attracted to a person based on who they are. It has nothing to do with their biology, their the way in which they present, etc. That you try and pay attention to who the person is, and that is what attracts you. It is something that is exploding, particularly among younger individuals. I have heard, as quite frankly, since coming to university and engaging more with people between the age of 18 and 24, that bisexual is often a category that's being used interchangeably with pansexual. Bisexual often is being perceived as like in between, anything in between, anything outside of, like if not given the category of pansexual or something else, that's part of what's really driving this increase in the numbers of people identifying as pansexual. Queer is an umbrella term for belonging to LGBTQ community. And it's interesting because there's a real age difference that increasingly younger people are using this, whereas still often people 40 and plus view queer as derogatory and problematic, et cetera, and just really unwilling to reclaim it in a way that I think younger individuals are. Asexual, a person who experiences little or no sexual attraction, and then two-spirit, a person who identifies as having both masculine and a feminine spirit, and is often used by more Indigenous groups. So I think this list could go on way longer, and we could have an entire course just on this list. I think what I'd like to do here is just highlight the fact that rarely, if ever, are these questions asked on state and federal surveys. And further, that by limiting it to these top categories, we're actually missing a lot. And then at the same time, as a public health practitioner, and if anybody here, and I know many people have done large scale empirical analysis, it is exhausting if you have 26 categories. You know, how do you collapse them? What's appropriate? How do you really tell if there are subgroup differences? There's a lot of challenges in increasing the long list of different sexual orientations and identities. And it's important to consider what are the trade-offs of providing a whole long list versus forcing, encouraging people to fit themselves into existing categories. All right, so what we're gonna, I think, one thing I would love for everybody to walk away with from today is the idea that if we don't ask these questions, you don't know what you don't know, right? If we don't ask these questions, then we are not going to understand the degree to which LGBTQ individuals are disproportionately impacted by certain things. And I think a lot of people expect me in this position to say, like, we always have to prioritize LGBTQ individuals, always. And we always need to tailor and make appropriate. Maybe, maybe not. What I will say always has to be done is asking the question so we can look at the data to figure out when LGBTQ individuals are disproportionately impacted by something and when they're not, right? And I can make that argument 27 different ways, even from an economic perspective. Like, let's not take the money to further tailor and make something unique to a certain subpopulation if they're not experiencing it any differently compared to other groups, right? But we don't know unless we ask the questions and include it. So this right here is what was came out of the most recent recommendations that I think is the collaboration of NIH, I think NSF and NCSES, if I got that right. And so it's a two-step question. First is, what sex were you assigned at birth on your original birth certificate? And then what is your current gender? And then basically in the analysis, you can look at how those two are similar or different. Some of the work that I'm doing on this right now, I like to constantly talk about the importance of including these questions, right? I think some people here today are LGBTQ experts in their own right. And I think some people, maybe this is new to you. Like, my hope as a function of being here in the School of Public Health in UAB is that someone in the environmental health department who's required to attend this will then go forward on to, what is the name of an environmental organization? Give me one. Yes, great. And then when they're rolling out their survey, they will know we need to include gender identity and sexual orientation, right? That we need to include these to understand if and when it's different. But if we don't, we won't know, okay? So Measure What We Treasure is a collaboration I'm doing with someone in School of Health Professionals, looking at both disability and looking at sexual orientation and talking about the ways in which that data is consistently not collected or ignored, and the way in which that then makes unclear how programs and policies need to better address unique individuals and differently abled individuals. And we were primarily focused on sexual orientation, not gender identity. Also, another study that I'm doing is in collaboration with, being funded by NSF. And essentially what we're looking at is completely different. Everything I do is community engaged work. This is the other side of it. Right. So NSF is saying that we need to basically look at, as we talk about a diverse workforce, we can't talk about a diverse workforce if we don't know the ways in which that diversity extends to sexual orientation and gender identity. So we're starting with the most basic question, which is, to what degree do STEM industries collect data on their employees with respect to sexual orientation and gender identity? Guess what we're finding so far? Like, think in your own experience. Have you ever on an HR doc filled out sexual orientation and gender identity? If anybody here is from UAB and is part of the process of HR docs or in the reporting, I encourage that to be included going forward. Again, if we don't collect this data, then we can't see differences in terms of retention, drop off, et cetera, of a workforce. We can't talk about having a more diverse workforce if we're not actually tracking these different dimensions of diversity, of which sexual orientation and gender identity is something that needs to be looked at. So I really make the same point over and over and over again. I promise I'll move on eventually. All right, so here's the recommended question in terms of sexual orientation. So lesbian or gay, straight, that is not gay or lesbian, bisexual, and then et cetera, et cetera. You know, one thing that I'll say about these questions in general that I consistently get is like, they're too private. Guess what? They're not. The data shows even among older individuals that people are less likely to answer with respect to income than they are for sexual orientation and gender identity. So ask these questions. If they don't want to answer, guess what? They can click prefer not to say and move on, right? And I was actually working with a local organization about how they could update some of their intake forms. And one of the things they said is that they're really open to it. They said, okay, well, we'll include these questions, but we really don't want to make people uncomfortable. So we're going to develop like a little speech that we'll say before we ask these questions. And I was like, please do not do that, right? Why? Like, why would a long introductory paragraph before you get this question potentially be problematic? This is a super easy question, guys. Come on. Yes. It just makes it a big deal, right? Like, let's just wrap this in. No big deal. Sexual orientation, gender identity, keep on moving, right? And if it's problematic, then they have the option of not answering and moving on, right? But until we start to make it more consistent to include these questions, and I just, let me stand on my little pedestal on the importance of this data. I really think that including these questions is also fundamental to reducing stigma and discrimination, because we're normalizing it. And we're saying that these identities and characteristics are not the only ones that matter, but they are just like race, ethnicity, age, and other key characteristics that define who we are. I'll try and move on from this point. I'll really try. It's just my career is contingent on it. It feels like. Okay, so here we go. In terms of numbers of LGBTQ individuals, so this was based on Gallup polls. So between 2012 and 2021, the percentage of people identifying as LGBT almost doubled. That is insane. Like a doubling of people who are identifying as LGBT. Now, I'll put an asterisk by the fact that we're actually looking at the Gallup estimates to try and understand how they got such high numbers compared to other national estimates, such as NHIS, et cetera. And we don't know if it's because maybe NHIS only calls people on a landline. And who has a landline currently? Can you raise your hand? Actually, don't raise your hand. That's like stigmatizing. Sort of. Delete. And so it could be a difference of landline, time of day that they're calling versus cell phone. It could also just be if you pick up the phone and someone's like, hello, I'm calling from the, what does NHIS even stand for, guys? It's a very long acronym that, yes, thank you, that one right there, versus, hi, I'm calling from Gallup. Like you say Gallup, and you know, everybody knows it, and so they feel more comfortable, et cetera, responding. So I'm interested, and that's one of the things that we're looking at is why they got such high estimates. But then maybe next year in the Epi seminar when we have pizza, I'll answer that question. All right, so another thing is the data is showing that, not surprisingly, younger generations are driving this increase. So 1 in 5 adults aged 18 to 23, this is still based on the Gallup data, identified as LGBT. Like, just take a moment to think about how big that is. 1 in 5, right? So fun fact, state of, nope, let me change how I say that. Something interesting to note is that the state of Alabama does not implement the SOGI module of BRFIS, so the sexual orientation and gender identity module. So that means that we currently do not have any statewide estimates of LGBTQ individuals. Don't worry, we're working on that. What we figured out, largely by a very smart person over here in the corner, is that we need to start having an understanding of what this actually looks like. So Magic City Acceptance Academy, which is one of the first LGBTQ affirming 6 through
12.
Sorry. 6 through 12 schools in the nation just started last year. And so one of the things that we're doing is we're basically, we looked at BRFIS and we figured out how to modify some of the questions, because some of the questions would be incredibly offensive if asked to an LGBTQ individual. And then Olivia over here is going to be the person who is running that survey at Magic City. And then the hope is that we do it every year. So even though it's just one school, it gives us a sense of what it looks like at this school compared to the country, which is huge. And my hypothesis is that a lot of the negative health outcomes that we see in the national data will actually be lower in this data as a function of the kids being part of an LGBTQ affirming school. Stay tuned. We'll also have updates on that next year. Okay. This is one of my favorite statistics. All right, what US region is home to the largest LGBTQ population in the country? Go ahead, shout it out. What do you think?
The South.
No, you're not supposed to start with that. Excuse me, I didn't mean to shout at a participant. Okay, if we didn't have incredibly informed individuals sitting there, what would most people say? That's when they'd be like, the West, because of the state of California. And then that's when other people from the audience would be like, no, Northeast, because that's where New York is, right? So that's what you're supposed to do. But instead, we have incredibly smart individual over here who beat me to the punch with my most favorite statistic and said that the South actually has the largest LGBTQ population in the country. So look, often like we put up statistics and it's important language data, et cetera. And like, let's just stop and think for a second, okay? Nationally, the South has the fewest protective policies for being LGBTQ across industries, education, housing, workplace, and still you have the highest number of people identifying as LGBTQ. Imagine, hopefully the direction we're going, right? If we were to put such things in place, the number of individuals that would actually identify as LGBTQ. So, you know, when I first started my career, I consistently got the feedback like, Sarah, just like do a broader focus on vulnerable populations. You know, include and it was always there aren't enough LGBTQ people. It's just not true. We are just barely starting to get the data to, surprise, surprise, show that queer people are everywhere, right? And then the question is, how now can we catch up to make sure that the programs and policies can actually be designed and developed and implemented, not just exist, implemented in practice to meet the needs of the LGBTQ communities that we have left behind consistently. All right, so now I'm gonna dive in a little bit in terms of health inequities. So I'm going to make some cross-cutting statements and then try and drive down and give some specific examples. So stigma and discrimination against LGBTQ persons has been associated with a high range of negative health outcomes. So physical, mental health, suicide ideation, attempts, substance use and abuse, and just a whole range of other negative health outcomes. I think increasingly as cancer centers, et cetera, are starting to incorporate measures on LGBTQ health. See, all comes back to the same thing. We are also seeing how in chronic diseases as well, that there continues to be inequities based on sexual orientation and gender identity. I think what I do want to also underscore is that there are dramatic differences by race, ethnicity, age, location, urban and rural, and by region. Those are all the things that we have at least some data on, but I also think it's based on being differently abled and a range of other different characteristics that largely is invisible at this point due to the lack of data. All right, so what I'm going to do now is just give a couple of examples looking at different subgroups. I think, you know, as I've been talking now, you know, I've largely been, I use queer as sort of an umbrella term. I've been putting LGBTQ together, and they're also, it's important to consider when there are subgroup differences, right? And again, how the actual provision of services needs to be different based on someone identifying one way versus another. So with respect to health inequities among gay and bisexual men, unfortunately, I think what has happened with HIV often overshadows a whole range of other health outcomes and considerations. And the rates are so dramatically different with respect to HIV that it's hard to not give attention to. So this is data based on the CDC. So 70% of new infections in 2019 were among gay and bisexual men. Giving just one example, you know, part of the reason why I'm highlighting Latino here as we drop into race ethnicity is because I think a lot of the work that's done, particularly in Alabama, often focuses on differences between Black and white. It's not to say that instead we should focus on Latino. It's just trying to give a snapshot today of why I think when we talk about race and ethnicity, we need to broaden who's included and how they're counted, okay? So just as an example, 24% of those occurred among Hispanic, Latino, and gay and bisexual men. With respect to PrEP, PrEP is a daily pill that if taken consistently and correctly can reduce the risk of HIV. I believe if we're talking about sexual intercourse, it's upwards of 99%, says the CFAR director. Got that right. So this one is that 85% of gay and bisexual men without HIV were aware of PrEP, and 25% of gay and bisexual men without HIV actually used PrEP. So awareness, right, to know something exists, and then you can know something exists and either choose to use it or not. Also, I just said choose to use it, and I think that's very problematic because that reduces the idea that like you make a choice and it's that simple without recognizing the larger structural context that often dictates access, ability to safely store the medications, et cetera, et cetera. So apologies for that reduction statement. And then you can see how that shifts when you start to look at Hispanic and Latino gay and sexual men. So giving one example of research that actually just came in through the door is we are going to work with AIDS Alabama, my co-partner Travis Smith, who's the director of prevention there, on developing hyper-local approaches to increasing PrEP uptake. I actually love this idea of hyper-local. Let me share why I love it so much. So I think as we develop public health strategies, there's constantly got to be this toggle of what is our general approach, and then how does that approach need to be adjusted, and what matters. So part of what I've been making the case for is adjust it based on someone being LGBTQ. Now I'm driving down to say, okay, but then what's the difference if someone identifies as a gay or bisexual man versus doesn't identify as that and just says, I have sex with other men? And then there's also, we're here in the state of Alabama. What we could do and design in Birmingham is likely very different than Mobile, Tuscaloosa, and other parts of the state. So this is going to be working with this local NGO, AIDS Alabama. They actually reached out to me and said, we are starting to deliver PrEP to the different communities that they work in. AIDS Alabama in particular is very well connected with different communities of color, inclusive of Latino communities as well. And they are just having a really difficult time with actual PrEP uptake, specifically at historically Black colleges that they're working at. And so we're working with them with this whole strategy, happy to talk more about it another time, to figure out how then in these different places, think about it. If you are walking through campus and you get a flyer or some sort of handout about what is PrEP and PrEP uptake, do you want that flyer to be something that caters to you identifying as a gay or bisexual man? Maybe, maybe not, right? And then what is your mindset when you are walking through campus that day, headed to class and get a flyer versus at a private event? And what flyer do you want to be given then? The idea is, I said hyper-local as in Birmingham versus Mobile, Alabama, but what we're actually talking about is in these different spaces, do we need to shift the messaging so that they're more appropriate so people can be more open and engaged and willing to hear more about it and then potentially consider PrEP going forward? Shifting a little bit to talk about health inequities with respect to lesbian and bisexual women. And I'm really, this is not meant to be obviously comprehensive of all of the inequities, but just trying to give some examples. So breast cancer compared to heterosexual women, lesbian and bisexual women are more likely to report risk factors for breast cancer. So this actually required a synthesis of multiple studies because it was like higher rates of alcohol use, smoking, obesity. How do I pronounce that? No, a little bit louder and no. Yep, that's recorded. And then barriers to seeking care, so lower rates of insurance and ability to obtain regular care, in addition to more negative past experiences with having sought care. So I think even in this one example, to understand how multi-layered it is, right, to address breast cancer. So structural, if we're talking about insurance, structural, if we're talking about engaging with a health provider and having a negative experience and therefore not wanting to come back even if you do have insurance, and then the quote unquote individual behaviors of drinking, smoking, etc. And I say quote unquote again because drinking, smoking do not happen in a vacuum. They often are coping responses to lifetime experiences of stigma and discrimination. They can also be just some of the few places that you can go as a queer person to connect with other people, right? So the complexity that it takes to really think through the multiple layers and levels that influence these inequities is quite complicated. All right, so shifting a little bit to laying out some of the health inequities among transgender and gender diverse individuals. So in many ways, the LGBTQ umbrella makes sense, right? And often when you drill down into data, when trans and increasingly trans and gender diverse people are included, almost always trans and gender diverse people, the health outcomes will be disproportionately more, even compared to those who identify as sexual minority individuals. Obviously, the answer to why is complex. Let me just throw out simplistically. I think there's this idea that sexual orientation is a concealable characteristic, which, like, I put a question mark by that, right? Because to navigate the world and to consistently have to drop the use of certain things such as pronoun versus husband, wife, to constantly make your language neutral, right? As you talk to coworkers, as you talk to colleagues, is exhausting. And I think there's a tax on that. That being said, there can be a real difference between quote unquote concealable characteristics of sexual orientation and then gender identity, and how challenging it can be for someone to truly quote unquote pass as a trans or a gender diverse person. It takes a massive amount of money out of pocket, more often than not. Also time, okay? It takes a lot of time in terms of to access the medications, gender affirming hormones, related surgeries, etc. Often in transition, and speaking with Dr. Ladinsky here at UAB, it's easily 2 to 3 years, right? So there often is a difference, and then again, layer on top of that legal and policy context, et cetera, et cetera. But I think those are some of the factors that contribute to why some of those rates are so much higher among trans individuals and gender diverse. So this data is very dated, 2015, but I'm excited to highlight and introduce Dr. Gabe Miller, a recent hire who's going to be in the sociology department and is part of the RWJF funding that you're doing specifically on the updated data. No, that's a completely different data set, but point being, a lot of what he's doing is actually working with data that hasn't yet become publicly available. And so I think his work in many ways is going to build out far more recent knowledge of health and well-being. So these are just some of the statistics in terms of pervasive mistreatment and violence, harmful effects on physical and mental health, and then the severe economic hardship and instability. And if you just look at these numbers, and again, just like take a moment, and when you think of like 1 in 10 people, these are really big numbers. And then I'll fast forward again to drop down and give a snapshot as it relates to Latino individuals. And you see that across each of those, the numbers then go higher. Reasons for what drives this intersectional minority difference, right, based on race, ethnicity, as well as sexual orientation, gender identity, obviously is complex, and often at the root of it can come down to different economic access to health, training to get the job, to pay for the house, et cetera, et cetera, et cetera. Where am I on time? Ooh, okay. Let me bring it home and then try and leave a few minutes for questions. So, not surprisingly, increasingly, one of the questions I get is, all right, so LGBTQ health inequities in the US, what makes it so different? Why are the rates so much bigger in the South? I can give you the answers right now based on the literature. I do really hope, as a function of living here, collaborating, building up friendships, that I improve my ability to give a more nuanced response. Right now, what I'd say is that often looking at some of the differences, it can be reduced down to looking at religiosity, rurality, and then poverty. Looking at that word in specific, think about internet access, right? What it means to have telehealth. What it means if you're in a community that is so much smaller than others, the likelihood of having a provider who's had training on how to give LGBTQ affirming care, services that provide LGBTQ affirming care. So one of the things I'm going to start doing is actually working with Dr. Pekmezi. She has an intervention that's trying to increase physical activity for individuals at home in the rural Black Belt. we are going to start looking at how to take this intervention that has shown early positive effects and adapt it for LGBTQ individuals in the rural Black Belt of Alabama. I consistently get the question like, are there gay people in rural Black Belt? And I'm yes. See, there's that one person here that says yes. Yeah, everywhere. Thank you. This is what I keep going back to. But here, this is going to be my challenge: is actually getting queer people in the rural Black Belt to, in fact, identify as such, right? So, what's interesting in terms of this 1 year supplement that I have from NIH, what we're proposing is not that much work. It's 20 qualitative interviews. It's going to be actually updating the intervention. And here's some of the questions. So right now it's an interactive voice response. And so they get a phone call, right? That gives them information. Do queer people want that voice to be more effeminate, or do they want it to be more masculine? Do they want some of the messages that they get to have some type of small signal, something that helps them know that this is like queer, safe, supportive? Like maybe they do not, right? But there's a lot of questions that we need to ask people living in the Black Belt just to understand how they want this to be adapted or not. But honestly, the first 6 months of this is literally just going to be me building relationships, going to the Rural Health Conference, driving out to Montgomery, connecting with, they just changed from Montgomery AIDS Outreach to, any chance you know? What is it?
Medical advocacy.
Thank you. Medical advocacy outreach. So, a big part of the type of research I do is literally just showing up again and again and again and again, sitting quietly for a very long time, which is hard for me to do, I do my best, and just listening, right? And then building that relationship over time and figuring out how I can use my research skills to best support the people, organizations in terms of the work that they're actually doing. Again, just dropping in a little bit deeper as we think about how these things are different, not just by region, location, but also race, ethnicity. This is something with respect to being Latino and LGBTQ. What does it mean when you're talking about the provision of services for undocumented individuals? Also very different from my experience in California. Most of the individuals that I've come in contact with so far are first generation, versus in Los Angeles, a lot of people were coming into multi-generational households of undocumented individuals. So there's already sort of a pathway, a working knowledge of how you navigate a system. And never mind, a lot of that system in California is already built for people to not actually have to show a social security number. So for example, I'm working with someone in California, an openly gay Latino man who got his PhD from Berkeley, and he can be hired by organizations and paid by organizations without a social security number. That is not the case in Alabama. So how do I have one of my top collaborators who is working on building out a mindfulness intervention and program with Latinos living with HIV here in Alabama? And this is something that my partners at AIDS Alabama said, we've heard men for our community asking for this, and I know someone who's great to support it. And then I am working on finding a mechanism to pay him because of the way systems are set up such that someone has to have a social security number here to be paid, right? So even when you have the resources, right, of someone who can speak in a native language, connect based on personal experience, I still have to figure out the structural mechanisms to make sure that the person can be paid for the time and energy they're putting into this. Anybody has any thoughts on how to do that? Let me know. Okay. So just a couple other research opportunities that I have in motion, and really putting this out there because I know that part of this is having student engagement. So anything that you're interested in, please let me know. We can figure out how to make space for you. So there's an older group of LGBTQ individuals, and we have been meeting weekly, monthly to try and figure out how to, it started off as a focus on how to potentially build out some LGBTQ focused housing for older individuals. And it has gotten far bigger to even include how to create different social opportunities for engagement. And so it looks like soon, I'm hoping we call it Softy and 70, but we're going to have coffee talk and donuts to bring together these individuals who have largely been virtual for the last 2 years and just further brainstorm on what are some of the things that we can do to bring people together. Also doing something on sex work among LGBTQ individuals. This was brought up by by somebody in the community here who is connected to someone who's done some sex work and for a long time said, like, you need to look at this, you need to look at this, you need to look at this. And then finally we did, and the data is really from Birmingham AIDS Outreach, which credit to them to be collecting this data for a long time. But for example, one of the things that we're seeing is more men engaging in sex work than women. That is not any hypothesis that I would have given based on data that I've seen before. I definitely would have expected higher rates among trans women. So are we seeing a difference because of who we ask the questions to, of who walked in through the door? We're literally doing that work right now to try and figure it out. Josh is at the helm of that, and so very exciting. And then also working with Southern Equity, very long acronym that I can fill in if you want to reach out about this opportunity. They did a survey of LGBTQ individuals in the region. They've done state-specific reports. They have not yet done the Alabama-specific one, and so we're working with them. They kindly gave us the data to look at differences, both pre-COVID and then 2021, in terms of health needs assessment with respect to LGBTQ individuals. This being so important because, again, this is in the absence of having any other statewide data. And then the last piece with my collaborator here, Dr. Brooksford, looking at the unique needs of key adolescent populations in Brazil. So specifically at young, gay, bisexual, and transgender youth. And in many ways, it's building off of a lot of the work that I started however many years ago with that clinic that now has expanded from Salvador to Sao Paulo. And so Dr. Brooksford and I will be going shortly in September to meet with our collaborators and start figuring out the data, the qualitative interviews, et cetera. So with all of these, it's an all hands on deck. And if you're interested, please let us know. I think final thoughts and feelings, measure what you treasure, right? And then if we could get everybody to treasure sexual orientation and gender identity as much as I do, that would be great. Really, truly, if we together can collaborate and talk about the importance of constantly including this data in all of the work that we do, not just LGBTQ specific spaces. Training. So I have 2 certificate programs in motion, one undergraduate, one graduate. It's probably going to be a year before it's fully approved by UAB, but it's in motion. It's in motion, okay? And this will enable for students at the graduate level. So Josh Bruce and I are working on a service learning course because it's important not only that you have the content knowledge of what drives LGBTQ health inequities, what all of the data is saying, but then to be able to work with an organization such as Birmingham AIDS Outreach to understand what it looks like in practice. And frankly, if you can learn how to navigate LGBTQ health and advocacy here in the Deep South, like LA, New York, San Francisco, it's cake the problem, okay? So really trying to build up both the skills and knowledge base, but then the advocacy and knowing how to put that in practice. We are also trying to build it out in terms of the clinical space with the School of Medicine, so a lot of collaborations having there, of building a fellowship to provide LGBTQ affirming care. We're looking at multiple funding sources. NIH obviously is the big one, but then also trying to consider CDC, public health departments, et cetera. And I think across all of this, if I can advocate for the importance of these hyper-local approaches to understand when we need to dive in and really make it specialized, unique, focused, and when it's okay to zoom back out and make it something that isn't so tailored and focused. That was a lot of talking very, very fast. We just have a few minutes. I'll hang around. I am including my email up here. Please reach out, contact me. Happy to talk more if you're interested.